All right, everyone's joining. Good evening, everyone. I will wait as I see the attendees pop up before we fully get started. As everyone is joining. Okay. I think most people from the waiting room are in here now. So we have a really awesome topic presented today by Dr. Kim Lovie Murdaugh, who is a physician scientist and filmmaker passionate about using multimodal approaches to solve complex problems in medicine, drawing from an education in chemistry and engineering, as well as clinical training in internal medicine and radiology. She's developed new nanoparticles, medical devices, imaging methods, health screening resources, and AI-powered tools for preventative and diagnostic care in vulnerable patient populations. To broadly disseminate these advances, she collaborates with academic medical centers and community health organizations using a variety of modalities ranging from filmmaking to creative arts therapies. She is passionate about medical education and mentorship for underrepresented groups in science and medicine to foster diversity in the clinical and public health workforce. And she is going to present her clitoral ultrasound topic, overview and applications, which is really cool. And I've got to see it in action. So welcome, Dr. Lovie Murdaugh. And as you'll see in the chat, feel free to use the chat for discussions, and there were some announcements. The recording will be available and sent out to everyone in case you are joining late or need to leave early. And please use the Q&A box for questions, which we will get to at the end in about 40 minutes or so. So thank you, Dr. Lovie Murdaugh.
Thanks so much for that kind introduction, and thanks everyone for being here today. I wish I could see all of your faces, but hopefully over the next few years or so, I'll get to meet a lot of you. So we'll just go through clitoral ultrasound and leave plenty of time at the end for a Q&A. So some disclosures. One main one is that I'm an R&D consultant for GetSurray.com, which is actually related to the topic we're talking about today. It's a sexual wellness brand. So this is an overview of what we're going to be talking about today. I always say you can't do ultrasound unless you know anatomy and terminology. So that's first. We'll talk about the state of the science, where we are now. We'll talk about the clitoral ultrasound protocol that I developed, some clinical applications, some really creative research applications, and then with so much of what ISSWSH does, we talk a lot about advocacy. So that's a huge part of what I do as well. But first things first, happy International Day of Women and Girls in Science. So as I mentioned, you all are very familiar with mentorship and advocacy, and I wanted to thank you all for your work that you do. And I always like to pay a little bit of tribute to where I've been and the mentors who helped get me where I am today. So if it ever you feel that ultrasound is really tough, don't worry. I've been doing it literally for a third of my life. So I'm here as a resource for all of you. On the left was my first ever job ages ago at NIH. I had mentors who really believed in me and supported me. And then here we are on the right at an ultrasound scanning competition at Yale. So we won't be scanning tofu today. I will be telling you about the clitoris. So on that note, anatomy and terminology. Now, this is a little bit of a difficult topic because there's been a lot of different terminology used in the literature over the years when it comes to describing the clitoris. It can range from the different terms used in different languages, different institutions, whether you're an anatomist or a physician or a physical therapist. But there is some broad consensus on the terms that we can use. And wherever possible, I kind of put all the terms together. So we made this diagram, and feel free to use it. This information will be available after the talk. So if it's helpful for your teaching, please use this. We have the body, the glands, the urethral opening. We also have the crus, aka the corpus cavernosum. You can see the labia minora here, this outline. We have the vestibular bulbs here. That's also known as the corpus spongiosum. And then we have the vaginal opening here. And we're going to go through all of this in a lot more detail. So what's in a name? As I mentioned, it is tricky because there are so many similar names for the same structure. So let's just review them again. So we have the glands. The body is also referred to as the corpus and is also referred to as the shaft. So it'll depend on what you're reading as to what term you'll encounter. The vestibular bulb is often referred to as the corpus spongiosum. If you don't know Latin, like I don't, I'm told that the plural, so vestibular bulbs or corpora spongiosa is how you make that plural. And then the crus, that's singular, aka corpus cavernosum, and then the plural is crura or corpora cavernosa. So we'll encounter all of these again as we scan, but just wanted to get these out there first. Now, this is an interesting bit of history, and I took this from one of Dr. Debbie Marshall's papers, and it helps, I guess, give some background as to why some of the terminology was referred to different things over the years. So historically, the vestibular bulbs and clitoris were thought of as separate erectile organs. So they weren't even conceived of as the same organ. But then anatomists noticed that the venous plexus of Cobelt really joined the vestibular bulbs closely, and you can see them coming together here. So, and aka the pars intermedia. So again, a lot of names. And so today, bulboclitoris is accepted as the unified term for the entire erectile organ. And that consists of, as we mentioned, the glands, the body, the crura, aka corpora cavernosa, and we can see that all laid out here. Now, this is another diagram that I really like because it shows the relationship between the vasculature and the nerves. So we can see that the main vascular supply is the dorsal artery of the clitoris, and we can see how close the nerves are and the veins as well. So we have the dorsal nerve of the clitoris, the dorsal artery, and the dorsal vein. And then we can see the deep dorsal arteries here intervening in the corpora cavernosa. And then you can see the septum here. One common teaching, it still rings true, and I think of it a lot from medical school, is that arteries run with nerves. So we'll just keep that in mind and we'll encounter that in ultrasound. Okay, so now that we have some anatomy behind us, what is the state of the science? So this next section is just going to be a lot of different papers that I've collected, pretty much everything that I could find about research studies on clitoral ultrasound. They're all going to be referenced at the bottom of the slides and at the end, so you can have those for your reference. So this is a really interesting study. They did a meta-analysis of clitoral measurements. So they looked at MRI, ultrasound, cadaver studies, and living people. And this publication, which came out a few years ago, just aggregated all of those and then basically aggregated these measurements that you can see. So here you have in detail the length of each different part of the clitoris. And so this might be interesting just as a reference as you're scanning your own patients. If you find a measurement that you're wondering if it's within the range of what's been documented and reported before, you can refer to this to see. And oftentimes, as you'll see in the literature, the measurements are in millimeters. That's often true for ultrasound in general. Now, this is an interesting study as well, and it comes up a lot because people often wonder if there's a way that clitoral ultrasound can convey some indication of cardiometabolic risk, the same way that penile ultrasound, if the vascular parameters are abnormal, that can be some indication of cardiometabolic risk in men. So what these authors did is that they looked at the color Doppler ultrasound and the clitoral and uterine arteries in women who presented with symptoms of female sexual dysfunction. And what they took a look at was the pulsatility index, and we'll go over what that means. So the pulsatility index, it's a measure of how much blood is flowing through the vessel. And in particular, you can think of it as a way to think about how much the blood speeds up and slows down in a vessel during the cardiac cycle. And it's given by this equation here. As much as I love equations, I just always love to translate them into words and think about what they mean practically. So if you think about what a high pulsatility index means, that means that the flow in that vessel is very pulsatile. That means that there are really big differences in those velocities, which means that you have very high speeds and very low speeds. And a hose is usually used as an analogy. So if you think about a hose and you narrow the hose, so if there's narrowing, there's going to be more resistance, and it's going to be harder to pump blood or pump fluid through that narrowed vessel. And so with that in mind, with that general concept of the pulsatility index, you can see that for these patients who were involved in this study, they found that patients who met the definition of obesity had a higher pulsatility index than those who were not obese. And so again, this is an interesting paper to read through. In terms of the statistics, if you look at the bars, so here you see a statistically significant result. But in this lower graph here, you see that it's not statistically significant. And so the researchers were wondering if they had enough, a large enough sample size to be powered to detect the difference between the two groups. Which brings us to a really important part and challenge of some of this research is that sometimes it's really hard to recruit study volunteers for clitoral ultrasound, given that so much of this is a very sensitive scan. It's not done in many places, and we'll get into that more later. Now, this is a study that was looking at the effect of hormone replacement therapy on clitoral artery blood flow. And this was studied in healthy postmenopausal women. And so as you can see here, again, we're not going to go through all the tables in great detail, but what they found is they compared the basal demographic data between the study groups. So in statistics, in any stats paper, your table 1 is going to be the table that tells you how your case group or how your experimental group compares to the control group. And they found that these groups were pretty similar. So they felt very confident with proceeding with their analysis. And in table 2, that's when they report how they compared the Doppler findings between the groups. And what they essentially found here was that the basal clitoral blood flow was determined to be higher in postmenopausal patients who had hormone replacement therapy in comparison with women who did not have hormonal therapy. And then they go in and study the pulsatility index and the resistive index. And because those values were not significantly different between the two groups, the authors were able to conclude that hormone replacement therapy improves clitoral blood flow without changing vascular resistance. So in that previous study, how we talked about if you narrow a vessel, that's going to change the resistance. Fortunately, these authors found that you were able to improve blood flow without changing that resistance at all. And this is one that I thought about a lot because in my practice now, I work a lot with patients who are smoking. And so this study looked at cigarette smoking and the effect of vascularization just in many regions, so in different parts of the body, in particular the clitoris and the vulva. And not too surprisingly, they found that cigarette smoking did impact blood flow to the clitoris. And the study was done a little while ago. In fact, these researchers, Vitalia, they were one of the early clitoral ultrasound researchers. So if these ultrasound images look relatively older to you, it's because the study is a little older, and this is just the machine that they were using. So what they did in this study, they did a very interesting 3D reconstruction of the clitoral vascularization. So you can think of these as, in a way, 3D averages of blood flow, mostly in the dorsal clitoral arteries, and then the branching vessels that branch out from that. And so from this, they were able to see, if you look at A, that was like the power Doppler histograms that they show, which kind of complex. We won't go into great detail. But the general conclusion is that cigarette smoking does decrease clitoral blood flow. And you can see that if you compare A and B. And this is a study that's often cited, and it makes me think of some of our patient populations who might be more sedentary. So this group of researchers looked at clitoral blood flow and sexual dysfunction in athletes. So they had two study groups. Group one was a group of elite female athletes, and they found a group that were professional volleyball players or handball players. And they noticed that everyone in this group had at least 4 hours of exercise each day. And then group two was a group of healthy sedentary female volunteers. And they defined sedentary as less than 2 hours of exercise per week. And what they were able to find, again, table one shows the demographics of both groups. And then in table two, that shows the blood flow parameters in both groups. And what you're able to see is that these elite athletes on the surface appeared to have, when you looked at all the parameters of clitoral blood flow, just increased blood flow compared to the sedentary group. And these p-values for most of the parameters were significant because the p-value was less than 0.001. But for a couple of these indicators, the resistive index and desire, they did see a difference, but that was not statistically significant. Now this might be, I'd say it was relevant to our practice, which we'll get into in a little bit, and it might be relevant for yours, but I think this study really puts into context I guess you could call it the disparity between men's sexual health and women's sexual health when it comes to diagnostic ultrasound. So in this study, they looked at mountain bikers and horseback riders, and the researchers were wondering if this repeated trauma to the groin had any impact on the clitoris at all. And so what they did is that they used grayscale Doppler and just did clitoral ultrasound. And by looking at the tissues, they were able to identify regions that were what you call hyperechoic. And so these corresponded to microcalcifications in the clitoral tissues. So I think that's interesting because if you think in the emergency setting, just say if a man presents to the emergency room after groin trauma, there's an ultrasound protocol. You would do a penile ultrasound protocol if it were indicated. But the question is anything done in the emergency setting for women? And so this study indicates that it could be very helpful. You could actually see pathology that could be informative in terms of correlating to the patient's symptoms. So that's a segue into how I got involved in this work. So I'm not sure if Dr. Murashi is on the call, but he's a dear mentor of mine, and we worked together for quite some time. And this was back in, gosh, the time flies. This was back in 2021, mid-2021. And I visited his OBGYN practice, and he asked me, Kim, how do radiologists evaluate the clitoris in terms of imaging. Like, what do you do in your practice? And I had recently finished my training, and I thought, oh, wait, I should know the answer to this. You know, that sinking feeling that you get when you feel like someone more senior than you knows the answer to something that you don't. And so I quickly went home and I searched for clitoral ultrasound because surely I knew about penile ultrasound. So it seems like you would do clitoral ultrasound. But when I went home and I looked, I saw that clitoral ultrasound had been done in the research setting, but I couldn't find anything in the clinical setting about it. So that was around April 2021. But then it just so happened that I was moving from New York. So Dr. Marashi practiced in New York City, and he asked this very thought-provoking question, but due to a number of different family and personal factors, I was moving to Paris. So I kind of meditated on his question, and I was also recovering from prolonged illness related to COVID. And as I was going through the different museums, the Louvre, um, taking pictures, I'm an avid photographer, I was thinking, you know, we should really develop some sort of standardized way to look at the clitoris, right? Like if there's a protocol for everything in medicine or radiology, like why isn't there a very simple, cost-effective imaging protocol for the clitoris? And so I read a few books in France. One was this one, if any of you speak French, I highly recommend it. It kind of translates to the clitoris laid bare. So it's like very, very interesting facts about the organ. Um, and I bought this model pelvis and was like trying to wrap my head around how I might develop a clitoral ultrasound protocol and like what are the different standard images you would need. So the first step of doing that, after you get a sense of the standard images that you need in order to feel like you've sufficiently imaged the clitoris, so once you have that, you can define it for the radiology community. So I don't know if you all know about Radiopedia, but Radiopedia is basically Wikipedia for radiologists. And it's a repository for every type of imaging study that you can think of. And as I had found out a few months before, clitoral ultrasound had not been defined. So the first thing we needed to do was define it. And it's fairly straightforward. Thinking back to the things that I've developed, this seemed like the lowest hanging fruit in a way, which, and I'm sure we'll talk about later, it made me quite sad actually to think about how this hadn't been defined. But in a very straightforward way, we just defined how clitoral ultrasound is this modality for imaging clitoral pathology, and this can potentially be the etiology of female sexual dysfunction. And you can use this before or after surgery, before or after radiation, any sort of treatment or trauma. And the link to the Radiopedia page is in the notes, but we just go through the anatomy of the clitoris, which we've gone through together today, and then the technique, which we'll get to right now. And the question that we get a lot is, why do we call it clitogram, or like, why did we trademark it? So we found that it's easier to communicate about any sort of imaging protocol, device, etc., if you give it a name, right? And so that's why we did that. That's not to say that everyone can't use it. Like we have this for, available for use. We have the steps of the protocol. I'll teach you now. Please teach your friends, and we'll jump right into it. So first, you place the patient in the dorsal lithotomy position. And then this is kind of hard to imagine in 2D, but you place the transducer on the vulva over the glands. And so this orientation is going to be the transverse, and this is sagittal. So you rotate the probe 90 degrees. And again, it's kind of hard to imagine in 3D, which is why I hope we can have a hands-on session. Now, what does that look like? So this is the sagittal view. We're going to label this. But before we do, here's a 3D model to help us with the sagittal orientation. And this is a great website where you can download and visualize a 3D model of the clitoris. You can even 3D print one if you'd like. So I'm very grateful to these authors for providing that open source. So I've placed the 3D model right next to the image. So if you can imagine this, we have the glands here, right? The glands, and then coming down. So if you can imagine this shape, orientation is helpful. So the ischiopubic ramus, the bone is this bright hyperechoic structure. And then we have the glands coming down into the bulbs. And you can take measurements as well. So we have the distance there, the distance there. You can also apply color Doppler flow. So this is a qualitative assessment of blood flow. It becomes quantitative if we attach numbers to it, right? And so this is a quantitative assessment. And so this is the dorsal artery of the clitoris here, seen in the sagittal view. And so this is that quantitative aspect that we were talking about. So if you put your gate over the artery, then you can get different velocity parameters. And you can even get a waveform at the bottom. And you can see it has this nice pulsatile arterial waveform. This is the transverse view. And we have the urethra here. And I'm going to, and we have the spongiosum here on either side. So we have the paired corpora spongiosa and the urethra. And to help us visualize that, we're going to bring the 3D model back. So as you can see, the terms get a little more difficult in different languages. I was learning all of this when I was living in France, so French is kind of my background to go to for this. But you have the spongiosa here, and then the glands is going to be coming out towards you in the transverse view. So let's take a look at those ultrasound slides again. So you can see the spongiosa here and the urethra here. And you can take measurements like so. So this is a video, and I'm going to try to move this here. So video can be more helpful to see as you're fanning through the structure. So by fanning, you place the probe down on your patient, and then without sliding the probe, you just rock your hand back and forth. So this is what that looks like. So I'm just fanning through. And again, ultrasound landmarks are helpful. So you can trace the urethra here, if you can see that, just fanning through. And then seeing the bulbs on either side. So you can see how they come together into the glands. You can also do color Doppler flow in the transverse section. And that's essentially what it is. I mean, it's not rocket science. I always joke, I did rocket science briefly. It's not rocket science. Here is the checklist for you to download, which goes through all of the steps. It has the technical notes, recommended transducers to use. I usually use a linear transducer, which its footplate is shaped like a little rectangle. That's a higher frequency transducer that's used for musculoskeletal, small vessels, smaller structures. These settings that I describe are going to be different depending on your machine and also depending on the patient as well. So here are some clinical applications, and we'll go through these a little more quickly. And some of these we already mentioned. So one can be establishing a patient's baseline and then changes on follow-up. So that could be an ideal scenario. So if you can imagine a world where with a GYN exam, we had everyone's baseline clitoral blood flow parameters, we'd be able to evaluate if a change occurred. Evaluating female sexual dysfunction, FSD, and this might provide some physiological explanation or anatomic insight into an underlying cause for some patients. As we mentioned, groin trauma, the standard of care for men in the emergency room is a scrotal and/or penile ultrasound, but what are we doing for women, right? And then pre and post vulvar procedures as well. Two applications that I want to highlight, in particular, we'll get into those, is survivors of FGM or FGMC. So pre and post vulvar procedures, if you think about all the intraoperative imaging we have intraoperative imaging for a lot of different surgeries. Orthopedic surgery comes to mind, for example. Do note that the nerves are not visualized on the clitogram protocol. So there are ways, I imagine, to evaluate the nerves on ultrasound if they're damaged, if there's surrounding fluid, if they're more hypoechoic than the surrounding area. But unfortunately, with this protocol and on this machine, I'm not able to visualize the nerves. But remember the adage, nerves and vessels run together. So if you are visualizing a vessel, the dorsal artery of the clitoris, know that the nerve is nearby. One other important thing is to evaluate for vulvar and clitoral hematomas after surgery. So if you imagine you have a patient in post-op and they have pain, it would be helpful if you could quickly scan the clitoris to see if there's any accumulating hematoma. One study that I'm working on with Dr. Marshall, she's the PI for the study at Mount Sinai, is to evaluate whether radiation therapy changes clitoral architecture and blood flow, because that's something that we just don't know. One other very important application, and Dr. Marashi has done a lot of this in his clinic, is for survivors of FGM and FGMC. And this is one of the reasons why he came to me in the first place and asked me if I would be able to develop a clitoral ultrasound protocol. So as you might know, FGMC really encapsulates all of the procedures that involve the partial or total removal of the external female genitalia or other injury to the female genital organs for non-medical reasons. And it's often performed on girls under the age of 5. Sorry. And it's deeply rooted in tradition and really perpetuated by societal norms and community expectations. And so this is a group that we've worked with called Orchid Project, and they're really working to help end FGMC. And so you can see by their map here, it occurs in over 90 countries globally. 4.1 million girls are at risk each year. And so what we did is we noticed that a lot of survivors of FGMC believe that their entire clitoris has been removed because that's what they've been told. But we were able to do clitoral ultrasound and scan the survivors and show them that the bulk of the organ, which is hidden beneath the skin, is preserved and can actually be stimulated. And in doing this work, we realized that a trauma-informed approach is paramount, right? If you can imagine any sort of trauma like this, some women might not want to see their ultrasound images. Some might feel empowered by seeing their images. So throughout this process, we reassured patients that any of those reactions is normal. And these scans were really meaningful. I noticed that they tended to conjure up a lot of emotions, like a lot of our patients cried during the scans, and we're just overwhelmed and relieved to find out that part of them, like a huge part of them, was still present. Moving on to some creative research applications. This was one of the first studies that we did. Once we realized that we could identify clitoral blood flow and quantify it, we wondered if there was any sort of topical gel that we could use to increase blood flow. So we did a pilot study mixing together different formulations of arginine and citrulline to try to increase blood flow to the clitoris. And we were actually successful in doing that. Again, a pilot study, so we would need a broader sample size to see if this was statistically significant. But we presented this at SMSNA. Again, the time is flying. I met a few of you there, but this was a few years ago now. And you can see from the poster here that the clitoral velocities, the arterial velocities increased with time after applying this gel. And we also wanted to see if we could offer any sort of therapies to patients, right? So we wanted to see if blood flow changed at all after using different sexual devices and tools. And it makes sense that it would, but we wanted to analyze that and just depict it on ultrasound, which hadn't been done before. And so by using different vibrators, one with a vibrating component, an air pulse component, and a wand, we were able to compare before. So the top panel is before with the transverse and sagittal views, and after blood flow. And this brings us to our final section, which is challenges and need for advocacy. As I mentioned, ultrasound is difficult to perform. There is a steep learning curve. I often take for granted how long I've just been doing ultrasound, but the more you scan, the more confident you'll be. So it is tough, but it's definitely something that you can achieve with a lot of practice. If you apply too much pressure, you can compress the small clitoral vessels. So that's one of the reasons why practice is needed, so that you don't compress too much. There aren't that many of us who are doing this. So I've talked to a handful of different clinicians who have been doing ultrasound scanning long before I've been scanning the clitoris, but it hadn't really been formalized in a way. Like, we didn't have the standard set of images. So over the past couple of years, I've been training as many people as I can, but I'm just one person. And this all points to a multidisciplinary approach being needed. So at your respective institutions, it would be really great if radiologists who can read about this protocol on Radiopedia can then get a sense of how to do the scans and then collaborate with urologists, OBGYN, pelvic floor physical therapists, etc. One clinical challenge is that there's no CPT code for clitoral ultrasound. This can be a barrier to billing and reimbursement. Whenever we did the scans in our practice, we did them free of charge. But I can imagine it's a challenge if you do want to bill for this. And if you think about maybe what would be the closest CPT code, I was thinking maybe 76870, but if you read the description of it, it's really described as genitalia or scrotal ultrasound, but if you read the description, it's just the scrotum and its contents. So it's just interesting to see how the clitoris is excluded once again. Perhaps CPT code for ultrasound pelvic non-OB might work, but in full disclosure, we haven't tried to bill for this. And again, one challenge and one need for advocacy is to help establish a normal baseline for patients. And this baseline can vary significantly between healthy patients. And so that's why having individual baselines can be helpful and might lead to more accurate diagnosis and management. One final set of challenges, as we mentioned, it can be difficult to recruit for sensitive scans. You need a multidisciplinary approach, and funding options, especially in this day and age, might be limited. So a lot of this research that we did was self-funded. With that said, the only way to get better at this is to practice. So please give it a try. If you scan this QR code, you'll be able to download the full protocol with all the images that I shared. And here are all of the references and further reading. They're also linked on the protocol if you prefer that at the end. And I will take any questions. Thank you so much.
Thank you so much, Dr. Lovie Murdaugh. We do have some questions in the chat, and I think some of the information will be reiterated in the slides. The link is in the chat where to find the recording once it's available. The first question, which was answered about the HRT paper, can you speak to, because the paper talking about postmenopausal women, they were using 0.625 milligrams of the conjugated equine estrogen plus 2.5 of the medroxyprogesterone acetate. Thoughts on vaginal or vulvar hormone use, like local use versus other systemics? I'm sure we don't have a ton of research on that yet, but your thoughts or what you've seen in practice, is there a difference in the application of the hormone or type of hormone used?
Great question. The short answer is I haven't looked into that, mostly because my practice is like the nuts and bolts of the scanning. Let me see if my colleague is here. I'm not sure if he's here, but I will look into that. I have a few ideas of people I can ask, but that's a great question.
Thank you. So the next question was, any research on clitoral changes with pelvic radiation? I know you mentioned that in one part of the slide, but any more information you could provide on
Yeah.
that?
Yeah, so that's an ongoing study that Dr. Marshall is doing at Mount Sinai right now. And to our knowledge, that's the first study that's looking at the effect of pelvic radiation on the clitoris. And so we're using ultrasound and MRI to take a look at that. And it's just one of those examples of something that if you had asked me if this was something that we knew, I would have just assumed that the answer was yes. In fact, I was recently talking to a good friend of mine who's a newly minted radiation oncologist, and we were just chatting about this work, and he just found it so hard to believe that we didn't know the answer to this. But I think that comes to it's just so important to have like a multidisciplinary approach, and some of these questions are hard to answer unless we get people with all sorts of training in the same room on the same research study.
Yes, and two questions kind of related to your device that you use, as well as how many megahertz is your specific transducer? I know you gave a range of what's ideal. Do you have a specific product you recommend or use, if you can talk about that? And yeah, what the megahertz is on your transducer.
Yeah, definitely. So I'll go back to this slide since that's helpful. In short, you can, and this kind of comes from our training where we were told to adapt to any sort of tool you had on hand, and we're kind of forced to adjust the gain and the different settings based on what you had. But given that you don't have to do that, you can really optimize your probe. So what I use is a portable ultrasound machine. It's a Philips Lumify machine, but there's nothing special about that one per se. It's just what I had. The more important thing is the transducer. So you want to use a linear transducer. And the one that I have is rated 4 to 12 megahertz. And so that's the broadband range. You can use an even smaller transducer, which they call the hockey stick transducer. It looks like a hockey stick. That's an even higher frequency and allows you to evaluate the vessels in a little more detail. The trade-off there is, though, you lose some of the tissue detail, the soft tissue detail. So I found that the linear probe is really good for optimizing, being able to see the actual architecture of the gland, the entire organ, the clitoris, as well as the blood supply. And if you have a freestanding machine, so like if you are not a radiologist out in the wild, right? If you have like an OB machine, that's even better. So the images that we were able to get, the best ones of the dorsal artery of the clitoris were actually on, let's see if it's this one. Yeah. So this image, we were able to get on on one of the OB machines that is just one of the freestanding ones, has more computational power and is more likely to be able to render the entire artery or more of the artery, if that makes sense. But you can get away with a portable machine.
Awesome. So as a non-imaging provider, because there was another question, so this is saying that an obstetric probe or vaginal probe, if that's all that was available, it has that capability, correct? Okay.
Yes, and the protocol even goes into some of the details, like just say you have an obstetric probe, which is the curvilinear one, it's curved. You can still scan with that. You might have to adjust your gain though to make the image look less dark. You might need to brighten it a bit and reduce the depth, since the OB probe is used to scanning like large depths for pregnancy.
Thank you. And then a couple questions about the use of 3D capabilities. And yeah,
Yeah, so that's a great question. I have not done 3D ultrasound for the clitoris, but it's closely tied to some of the research questions that I'm thinking about. In particular, how does you can think of like tissue elasticity, other tissue properties change with age, with hormone status, with radiation. So 3D would be helpful for that. I just haven't gotten around to it yet.
so everyone here that does 3D, maybe you can use her protocols
Yeah,
and start that.
yeah, definitely. That would be incredible.
We have some questions about various creams and other medications. So, have you measured clitoral blood flow after tadalafil use? Or there was also one about, I'll kind of group these together, the topical arginine in cancer survivors and response to sildenafil cream before and after use. I can repeat if you need.
Yeah, also great questions. The short answer is no, have not looked into any of that. Um, we have looked at arginine and citrulline cream incidentally in patients who've let's see, this was, yeah, this was a year and a half ago. So the effects of arginine and citrulline in some patients who have had cancer and saw that it increased blood flow, but haven't done any sort of like, I'd say, systematic analysis of that. Yeah. And I
Awesome.
guess all of this is in the context of this is kind of a side project for me, is not like my primary research focus or like primary job. So a lot of answers to these questions are going to be, I haven't done that yet. And this would be a very important area for research for anyone to tackle.
Awesome. And curious because you did study, you're talking about individual baselines, and hopefully, in the future we have more data on maybe established norms in different populations or different age groups. What would you think about different interventions like pelvic floor PT, medications, topical hormones? Is that kind of the future direction in your differential diagnosis? You get a baseline in somebody complaining of a clitoral pain or dysfunction related to that, and maybe they have a low blood flow. Would you like to study for future directions working in a multidisciplinary team with pelvic floor PT or trying different medications? Do you see that going in that direction for research?
Absolutely. I think that's kind of a holy grail in a way. If we are able to just bring in different specialists with different expertise, I'm always a huge fan of that. And just using this as a tool to establish baseline and then see responses to therapy. I know in my own experience as a clinician, not having an explanation for anything is very difficult, right? Like if it's hard to point to any sort of physical explanation for a patient's symptoms, it really leaves you in a difficult spot, and it can be very very psychologically difficult for patients as well, wondering if something is in fact wrong. Will they get better? How do we evaluate this? And so I'm hoping that ultrasound can just be a very straightforward tool for us to evaluate baselines, effects of change, effects of different treatments. So that's kind of ideal, I think, future direction.
Yeah, that would be awesome. Another question, understanding both vascularization, wow, I can't speak, and tissue dynamics, what is your opinion on the injection of intraglans and G area PRP? And do you envision any place for clitoral ultrasound in research or follow-up of this potentially therapeutic modality?
So I only know about PRP in the context of orthopedic cases. So in radiology training, I did part of my training at HSS, so Hospital for Special Surgery, where we were seeing a lot of athletes who had joint injuries and had PRP injections in the joint and seemed to find that that helped. I'm not very familiar with like the data on PRP injections in the clitoris. In terms of how that would, I suppose, alter blood flow, I think that is worth looking into. I know a lot of people who are, I guess, demanding more quantitative evidence about PRP injections in that area. Do you wonder if, wonder what are ways that we can measure the effect other than asking patients about symptomatic improvement or symptomatic relief? So I think any sort of additional quantitative tools that we would have to quantify that would be helpful. So I can see that playing a role. But as to the efficacy of PRP, it's unfortunately, I don't know in this area.
Yeah, it's so new anyways,
Yeah,
so interesting types of interventions.
yeah.
Um, have you seen a relationship between anorgasmia and clitoral vascularization or clitoral size? And I want to add on to that, potentially in those with any degree of clitoral adhesions, will this impact, I guess, the scan at all? And in your experience, have you seen that in the patients you've scanned?
Absolutely, a great question. These are all great questions. So you can see clitoral adhesions on the scan. They do appear as hyperechoic. Like if you've seen scar on scan, they appear very similar to scars on scans. And we had a patient once who did have clitoral adhesions after having a glans piercing years ago. And that piercing had been removed. She hadn't thought about it anymore, but was having pain in the area. And after scanning, we realized that there was an adhesion here, like it looked like some sort of scar. And upon further interviewing, she did endorse that she had a piercing there. So it is something that you can see and can evaluate for.
Yeah, interesting. So one from a Eurogyne. Any chance that this will be helpful to evaluate periclitoral abscesses or urethral diverticulum, or even help with vulvar Crohn's? Do you see future for that?
Yeah, absolutely. So great question. And I think this comes down to getting more practice scanning patients and just having a really great sense of what normal ecotexture looks like. So, like any other scan, the more you practice, the more comfortable you'll be. And abscesses are very, I'd say, very clear to identify on ultrasound. Like any other part of the body. And I imagine I haven't seen one. I haven't seen a periclitoral abscess or clitoral abscess, but I imagine it would appear very similar. And so I guess number one is that just having a sense of what abscesses look like in the other parts of the body, you can infer for the clitoris. In terms of Crohn's, so that gets to just having a sense of what normal ecotexture looks like and just getting a sense of changes to the organ. So I think there is a role for it.
Thank you. And then sort of a side question just about research in general, or evidence-based data on the relationship of clitoral size and orgasmic response. So not specific to the ultrasound technique, but are you, or if anyone's aware, somebody was asking about that in the Q&A.
So I haven't seen that described in the literature. Just thinking. So the one study, that meta-analysis of, I think it was far back in the slides, but this meta-analysis of right here. Yeah. I believe I will have to take a look, but I believe one of these studies looked at a correlation with the FSFI in terms of clitoral size. I don't think anorgasmia in particular, but, if they did, I don't remember how large that sample size was, but I think it's in this paper. Sorry, it's been a lot of papers over the past long time. Yeah.
I think something that could be cool and useful just to add into your research with using stimulus, doing a baseline and then having somebody use a vibrator and then redoing it, is some of the studies looking at the vibrators that collect data on like orgasm. That would be a really cool study to do, since they are looking at that with the use of vibrators and collecting data. So that could be a cool piece to add in for that as well.
Definitely.
And lastly, are there any ultrasound basic or advanced courses that you'd recommend for those wanting or that are novice in the ultrasound scanning world to take? And more onto that, like, where can people learn to do this? Like, where do you have resources for people to take courses specifically for this, or any other resources you may have?
Awesome question. And I will send you some resources after this, but I'm a huge fan of the acronym is SAEM, SAME. So I think it's maintained by emergency medicine physicians, and they have some really incredible videos about the basics of ultrasound scanning, how to get comfortable scanning. It's helpful if you do have access to like a portable ultrasound, or even if you have a freestanding one. You can scan a friend. Honestly, that's how we all learned when we were first year medical students learning how to scan. We just scanned each other. And we went through these, I think they're all on YouTube actually, but we just went through these modules of getting comfortable, adjusting the different settings, adjusting the gain, adjusting everything you could possibly want to adjust. So that's what I'd recommend for like general ultrasound scanning. In terms of training for this protocol, so I did do a couple of training sessions. Dr. Marashi and I hosted them this was last year and the year before. And those were a lot of fun. We don't currently have one scheduled, but if you reach out to me and you're interested in learning, we can try to set something like that up. Yeah, as I mentioned, like this is kind of like at this point, a side project for me, and I'm doing full-time work and something entirely different. But if there's enough interest, we can try to figure out something.
Well, maybe in the future, ISSWSH can bring you in as part of the hands-on course for the annual conference or the fall course. And there's information
Yeah.
in the chat if anyone's interested in learning more, joining as a member with ISSWSH. But thank you so much. This was an incredible
Yes.
webinar, and I see lots of amazing comments and people loving it. So good
Awesome.
night to everyone, and thank you so much.
Thank you so much. Appreciate it.
Bye, everyone. Good night.